Good morning, my respected teacher, my colleague. Today, my topic of discussion is seronegative autoimmune encephalitis, the diagnosis, approach, differentials, and management. Myself, Dr. Amlan Tarai, and I am presenting under guidance of Dr. Kiren George Kosi, sir. First, the scheme of presentation today, the introduction. When do we suspect autoimmune encephalitis? Mimickers of autoimmune encephalitis. How do we approach? And classification, criteria of seronegative autoimmune encephalitis, differential diagnosis. Test doesn't always imply accurate diagnosis. Some patients with autoimmune encephalitis might not respond to immunotherapy, could need intensive and prolonged therapy. Now come to the definition of autoimmune encephalitis. Autoimmune encephalitis comprises a heterogeneous group of immune-mediated CNS inflammatory disorder, and that is mediated by antibody directed against cell surface or intracellular neuronal antigen. So type of autoimmune encephalitis are three categories. One is antibody directed against extracellular neural antigen, antibody against intracellular onconeural antigen, that is the paraneoplastic, and seronegative. One is the extracellular neural antigen, another is intracellular, that is onconeural antigen, and seronegative, where the antibody is negative. When do we suspect the autoimmune encephalitis? The diagnostic criteria, it is depicted by 2016 autoimmune encephalitis clinical criteria by Gruss et al. And diagnosis is made by all of the three of the following criteria. That is subacute onset, rapid progression of less than 3 months of working memory deficit, short-term memory deficit, altered mental status, and psychiatric behavior. At least one of the following. It includes new focal CNS findings, seizure not explained by the previously known seizure disorder or epilepsy, and CSF pleocytosis that indicate inflammatory change, and MRI feature suggestive of encephalitis and reasonable exclusion of all. Now come to the mimickers of autoimmune encephalitis, that is the exhausted list. So come to the step by step. First of this, we have to exclude the CNS infection like herpes simplex infection, human herpes 6 encephalitis, neurosyphilis, whipples, and HIV, post-COVID, drug toxicity, and also sometimes in the first onset of the psychosis or psychiatric disorder may present like autoimmune encephalitis, and functional neurological disorder, chronic fatigue syndrome, Creutzfeldt-Jakob disease, neoplasm, mostly glioma and lymphoma, and rapidly progressive neurodegenerative disorder, epileptic disorder, because autoimmune encephalitis is present as a three main characteristic feature. One is the seizure, movement disorder, and also the neuropsychiatric behavior. Rheumatological disorder like SLE and Sjogren's sarcoidosis, and Klein-Levin syndrome, Reisz syndrome, mitochondrial disease, and inborn error on metabolism in children. What investigation we should proceed for the when a suspected case of autoimmune encephalitis? How do you proceed for step by step? Step one, we go for the MRI of the brain, confirming the presence of focal or multifocal brain abnormality suggestive of encephalitis. So importance of the brain MRI, in addition to ruling out of the alternative diagnosis like acute stroke, neoplasm, or Creutzfeldt-Jakob disease, MRI brain with contrast can show change consistent with one or more of the autoimmune encephalitis anatomical syndrome. Here we see that is limbic encephalitis. It is depicted here. The mesial temporal lobe is affected in hyperintensity. So anatomical subtype of the autoimmune encephalitis done by the MRI brain. So A depicted here limbic encephalitis, B is cortical and subcortical encephalitis, striatal area affected in C, that is striatal encephalitis, diencephalon is affected. In that case, we can see that is diencephalon encephalitis, brainstem encephalitis, and meningoencephalitis. So through MRI, we can anatomically differentiate different type of autoimmune encephalitis. MRI brain, according to 2016 autoimmune encephalitis clinical criteria by Gruss et al., the presence of bilateral limbic encephalitis is the only MRI finding sufficient to diagnose definite autoimmune encephalitis in the correct clinical setting, even in the absence of antibody. So if there is antibody absent to diagnose a case of limbic encephalitis, MRI findings is sufficient. And sometimes in autoimmune encephalitis, brain MRI may be normal, unilateral, in the lesser extent bilateral, inflammation of the mesial, non-mesial temporal lobe, as well as the orbitofrontal cortex, FLAIR or DWI sequence support herpetic encephalitis over autoimmune encephalitis. Now come to the EEG. Findings suggestive of autoimmune encephalitis include focal slowing, seizure, lateralized periodic discharges, and or extreme delta brush that is significant, which is occasionally seen in NMDR antibody encephalitis. And EEG also help to differentiate autoimmune encephalitis from CJD. Autoimmune encephalitis is the major cause of the new onset refractory status epilepticus, that is NORSE, which can be convulsive or non-convulsive. Now come to the brain FDG PET. In case of negative, where the negative brain MRI and clinical uncertainty, despite high suspicion of the autoimmune encephalitis, brain FDG PET can confirm focal or multifocal brain abnormality in the correct clinical setting. In some case series, brain FDG PET was more sensitive than MRI and may reveal brain abnormality at early stage of the disease. Brain MRI FDG PET showing bilateral temporal hypermetabolism that's seen in seropositive or seronegative limbic encephalitis, when bilateral occipital or parietal hypometabolism actually seen in NMDA or encephalitis. Now come to the step 2, confirming the autoimmune inflammatory etiology. We excluding the other possibility. We first go through the CSF analysis. Regarding findings, all patients with suspected encephalitis require LP unless there is significant contraindication of LP. If timely brain MRI possible due to patient agitation or lack of access, clinician should proceed with LP after screening CT scan of CT head so as not to delay immunotherapy. So how do you proceed for investigation? Investigation in the one is the blood and CSF. Both blood and CSF we routinely do. Routine blood test including CBC, electrolyte, and creatinine, liver function, and glucose. And for CSF, that is cell count, cell type, protein, sugar, oligoclonal band, IgG index, and cytology for the rule out malignancy, and oligoclonal and IgG index for to see the whether inflammatory change present or not. Metabolic screening, TSH, and vitamin B12 and toxicology when suspecting the case may be related to the toxicology. So toxicology screening is required. And to rule out the systemic autoimmune disease, ANA and vasculitic profile like ANCA profile. And most important, the infectious disease, to rule out the infectious disease, most commonly HIV, hepatitis B and C, respiratory viral panel, arboviral, syphilis screening, Lyme disease, TB, and in case of CSF, we exclude for the viral etiology like herpes zoster virus, varicella zoster virus, herpes simplex virus, enterovirus, CMV, herpes 6, JC virus. Also, we can exclude the bacterial culture to rule out the infection, bacterial infection, culture and sensitivity. To rule out the tuberculosis, mycobacterial culture or AFB smear. Syphilis, when suspecting the syphilis, CSF syphilis for BDRL. Cryptococcal testing, fungal culture, And most commonly, the specific autoantibody testing, that comprehensive neural antibody testings, it may be including the surface antigen and also intracellular antigen. And other antibody testing on the based on the clinical phenotype, like when you suspecting that associated with the MOG, aquaporin 4 or GQ1B ganglioside antibody, and flow cytometry required to exclude a malignancy. The CSF clinical CSF feature in case of autoimmune encephalitis. CSF findings is the mild to moderate lymphocytic phagocytosis more than 5 cell. Increased protein level is elevated IgG index and positive intrathecal oligoclonal band. Routine CSF study may be normal in some autoimmune encephalitis patient. So testing the antibody, neuronal antibody panel is recommended. In case of high clinical suspicion, if the CSF is also normal. So neuronal antibody in testing is both important in the CSF and blood, because CSF detection is more sensitive antibody like FAP antibody, and serum is other antibody like onconeural antibody, LGI1, aquaporin 4, and MOG. So both serum and CSF study is needed to actually diagnose what type of encephalitis it is. Now come to the brain biopsy. Brain biopsy actually needed for the atypical or mass-like lesion to exclude the neoplasm, other possibility, especially when all other investigation point away from autoimmunity. We suspecting it may be the neoplasm or malignancy. In that case, brain biopsy required. Now come to the screening of associated neoplasm. Most common neoplasm associated with autoimmune encephalitis include small cell lung carcinoma, thymic neoplasm, breast cancer, ovarian teratoma or carcinoma, testicular teratoma or seminoma, neuroblastoma, and lymphoma. So how do you proceed for the screening of for neoplastic screening? Or now come to the neoplasm screening protocol. Suppose one patient diagnosis is NMDA encephalitis, antibody comes positive NMDA encephalitis. So we basically know that it is associated with ovarian teratoma. So in specific case, in that case, specific neoplasm suspecting the ovarian teratoma, we go for the USG of the abdomen, direct neoplasm screening. If the ovarian teratoma is positive, so in that case, neoplasm identified, further monitoring and treated as per oncology guideline. Suppose the antibody, the directed screening is negative. In that case, we go for an extensive study like CT scan of the brain, CT of the body. And if CT of the body is negative, so go for the mammography or breast MRI, pelvic or ovarian testicular ultrasound, and considering comprehensive skin examination and endoscopy. All these reports are negative, so go for body PET scan. So body PET scan actually more significant whether intermediate and high risk antibody is present. So in that case, body PET scan is significant. If CT scan of the body and mammography all are positive, so we go for the neoplasmic identification of the neoplasm and monitoring and treatment as per oncology guideline. So here, if there is all neoplasm identified, so in that case, repeat screening every 3 to 6 months for at least 2 years in patient with intermediate high risk antibody is recommended. Now come to the proposed classification. I already discussed about the anatomical classification based on the MRI findings, and serological classification all discussed about the seropositive, seronegative, where the antibody against the cell surface and antibody against the intracellular antigen against intracellular antigen, and the seronegative. Other classification, etiological classification, the autoimmune encephalitis may be idiopathic, paraneoplastic, post-infection, and iatrogenic due to the drug related. It may be the immune checkpoint inhibitor or tumor necrotic factor alpha monoclonal antibody. Now come to the serological classification. Based on the serology, there is final category will be 3 category: definite, possible, and probable autoimmune encephalitis. To diagnose the definite autoimmune encephalitis, antibody positivity is required. But in case of possible and probable autoimmune encephalitis, antibody positivity not required. But some exception is there. So suppose one patient has a possible the definite possible and probable autoimmune encephalitis, definite autoimmune encephalitis for which autoantibody status is often needed, possible and probable autoimmune encephalitis for which autoantibody status is not needed in most cases, and probable autoimmune encephalitis underlying pathogenic mechanism is unclear, but autoantibody status is not needed. Now come to the possible autoimmune encephalitis. So if one patient is possible, we suspecting the possible autoimmune encephalitis, but antibody is not positive, but in that case, we can definitely say it is a limbic and definite limbic encephalitis on the background of when bilateral mesial temporal MRI PET scan is so directly clinical and radiological parameter, we can directly say it is a definite limbic encephalitis. But in case of the possible autoimmune encephalitis, where the antibody directly we can say that is definite autoimmune antibody positive autoimmune encephalitis. Another criteria where we can say the possible when go to the probable autoimmune antibody negative autoimmune encephalitis, in that case antibody will be negative with some parameter like MRI consistent with autoimmune encephalitis, CSF pleocytosis oligoclonal band and elevated IgG index, that is indicating the inflammatory change. So definite autoimmune encephalitis is the first category which include the syndrome that has established clinically or occur with well-established antibody like limbic encephalitis, ADEM, and antibody positive disorder. In case of limbic encephalitis and ADEM, no need of antibody positivity, and other case to diagnosis or confirm or to stamp as a definite autoimmune encephalitis, antibody test is needed positive. Now come to already said that bilateral mesial temporal MR hyperintensity in the absence of antibody. Diagnosis made by the 4 of the following criteria, that is subacute onset, rapid progression of the less than 3 months of working memory deficit, seizure and psychiatric manifestation, and bilateral brain abnormality T2 MRI flare hyperintensity, and at least one of the following: CSF pleocytosis, that WBC count more than 5 cells, that is inflammatory change, and EEG with epileptic or slow wave activity involving the temporal lobe, and reasonable exclusion of the alternative diagnosis. But if there is 3 criteria, 1, 2, 3 criteria not matching, so in that case, antibody is required to diagnose a case of definite, to stamp as a definite autoimmune encephalitis. Autoimmune limbic encephalitis already described what is the importance of the antibody. So measurement of the antibody in case of autoimmune limbic encephalitis is important for the 2 reasons. One is the clarification of the immunological subgroup of limbic encephalitis, and patients who do not satisfy the diagnosis of autoimmune limbic encephalitis. Now come to the ADEM, that the diagnostic criteria of the definite ADEM, acute disseminated encephalomyelitis. There is the 5 criteria, 5 point is there, that the multifocal clinical CNS event of presumed inflammatory demyelinating cause, encephalopathy that cannot be explained by fever, and abnormal MRI findings, that is diffuse, poorly demarcated, more than large, that is the more than 1 to 2 centimeter lesion, predominantly involving the cerebral white matter, and T1 hypointensity lesion in the white matter in rare case. And sometimes the deep gray matter like thalamus or basal ganglia may be affected, but no new clinical or MRI findings after 3 months of symptom, because ADEM is a monophagic lesion. So later on, when see the after 3 months, there will be no lesion, MRI, no clinical findings, and we exclude the another reasonable exclusion of the alternative cause. There is no specific biomarker of the ADEM. Actually transiently occur in the almost 50% of the children of ADEM. At present, the inclusion of the MOG antibody in diagnosis criteria of the ADEM is not considered for the two reasons. One is the sometimes MOG, it is a non-specific antibody. So the antibody can be present in demyelinating disorder with encephalopathy, but without MRI findings, without MRI feature of ADEM, or sometimes in patient with demyelinating disorder without encephalopathy. And another condition, antibody testing remain unavailable in many centers. So that's why MOG antibody not included in the criteria to diagnose of the ADEM. The typical MRI finding large in white matter. We can see here that is a DFIA more than 2 centimeter hyperintense lesion, T2 flare that present in the supratentorial white matter. Now come to the second category, the probable autoimmune encephalitis. Probable autoimmune encephalitis, which include less well-established syndrome that can occur with or without antibody. Probable autoimmune encephalitis, including the biggest of brainstem encephalitis with GQ1B antibody and Hashimoto encephalopathy. In biggest of encephalopathy, biggest of brainstem encephalopathy, it may be two parameter. One is we can diagnose the probable biggest of, and another is the definite biggest of. In probable case, 3 criteria. One is the rapid onset less than 4 weeks of the following symptom with the decreased level of consciousness, bilateral external ophthalmoplegia and ataxia, and reasonable exclusion of the alternative diagnosis, alternative cause. But if all 3 criteria didn't match, so in that case, we need to diagnose the bigger stuff encephalitis, GQ1B antibody should be present. In case of Hashimoto encephalopathy, the 6 of the following criteria have been met. One is encephalopathy like seizure, presentation, myoclonus, hallucination, and subclinical or mild overt thyroid disease like hypothyroidism, brain MRI normal or non-specific abnormality, presence of thyroid antibody. The thyroid antibody, there is no specific cutoff line. The specific cutoff value for this antibody, for anti-thyroid antibody, sometimes is detected in 13% of healthy individual. Absence of well-characterized neuronal antibody in the serum and CSF, and exclusion of the alternative diagnosis. So definite diagnosis based on the clinical, radiological, serological findings. The definite diagnosis of because of encephalitis can be made if the GQ1B antibody are present, and definite diagnosis of the limbic encephalitis and also ADEM presence or absence antibody not required. Now come to the probable seronegative autoimmune encephalitis. It is a final discover a novel antibody. Diagnostic panel test only known for the only known antibody like NMDA, LGI, Casper, AMPA, and GABA, and patient may have antibody targeting novel neuronal antigen not included in the standard commercial assay. Point number 2, the low antibody titer below detection threshold. Some patients produce antibody in the very low quality, especially in the early disease or after immunotherapy. Sensitivity of the cellular cell-based assay or immunoblot assay may not detect them. When we only investigation do the CSF, so only antibody missed by the serum testing. Some antibody present in the CSF, some are more present in the serum. So if I NMDA, think about the NMDA that most present in the CSF, if only serum test is done, test may be falsely negative. Now come to the T-cell mediated autoimmune encephalitis. In paraneoplastic, the immune response in T-cell mediated, not humoral. In that case, antibody may be present. Technical limitation of the current assay. In commercial kit vary in sensitivity, antigen expression. Some cases are often detected using the advanced tissue-based assay or immunohistochemistry not routinely available. Sometimes the diagnosis, misdiagnosis. Suppose some patient initially labeled as the seronegative autoimmune encephalitis, but later on the diagnosis, confirmed diagnosis will be the viral encephalitis, genetic or metabolic encephalitis, psychiatric illness. So careful workup is needed to exclude mimics. Now come to the clinical feature of seronegative autoimmune encephalitis. It is a heterogeneous group of disorder commonly encountered in the clinical practice. Seronegative autoimmune encephalitis actually clinically indistinguishable from seropositive case. The predominant phenotype was acute short-term memory impairment, disorientation or confusion, seizure, and prominent psychiatric feature less common than seropositive case. Now come to the clinical feature of criteria of the probable antibody negative autoimmune encephalitis. Criteria for probable antibody negative autoimmune encephalitis: rapid progression, subacute onset, less than 3 months of working memory deficit, short-term memory loss, altered mental status or psychiatric symptom, exclusion of well-defined syndrome of autoimmune encephalitis like limbic encephalitis, ADEM, or because of brainstem encephalitis, absence of characterized on autoantibody in serum and CSF, and at least 2 of the following: MRI finding suggestive of autoimmune encephalitis, CSF pleocytosis, CSF oligoclonal brand, and elevated IgG index that indicate inflammatory change, brain biopsy showing inflammatory infiltrate, excluding the other disorder like vasculitis or tumor, and reasonable exclusion of alternative cause. Now come to the differential diagnosis of the autoimmune seronegative autoimmune encephalitis. First, an infectious cause. First, you have to look about the differential diagnosis: CNS vasculitis, Suzak syndrome, Base neurobase, Rasmussen encephalitis, encephalopathy after infection or vaccine, infectious cause like viral Borrelia or syphilis. Now come to the differential diagnosis. Another differential diagnosis that antibody associated autoimmune encephalitis that are infrequently considered. So in 3, that is the anti-GBA antibody, and cortical encephalitis like flame, that is the subtype of Mogard, and anti-Iglon disease. So in 3 disorders that are associated with neural surface antibody. So sometimes it is a misdiagnosis with probable antibody negative autoimmune encephalitis laboratory, and cortical encephalitis associated with MOG antibody, because this disorder can occur without white matter change in MRI. That case, testing might not be considered. Now come to the non-inflammatory disease like cryptogenic NORS, pandas and PANS, and first episode of psychosis disease, primary CNS lymphoma, Creutzfeldt-Jakob disease, leukodystrophy, and mitochondrial disease. Another 3 exclusion disorder in the differential diagnosis of the probable antibody negative autoimmune encephalitis like NORS, that is the new onset refractory status epilepticus. Pandas is the pediatric autoimmune neuropsychiatric disorder associated with the streptococcal infection, and pediatric PANS, that is the pediatric autoimmune acute onset neuropsychiatric disorder. Actually, pandas under the subtype of PANS. What is NORS? NORS is defined by the clinical presentation, not a specific diagnosis. Disorder with new onset of refractory status epilepticus without a clear acute or active structure, toxic or metabolic cause. Most commonly, etiology is the cryptogenic, around 50% of the case, and autoimmune is 36.2% of the patient. NORS may result from the post-infection proceeding to cerebral inflammation. CSF often reveal a non-specific pleocytosis and mild elevated protein level. Now come to the pandas. Pandas and PAN are 2 syndromes present in the abrupt onset of OCD associated with tic hyperactivity or coriform disorder, coriform movement disorder, along with other neuropsychiatric alteration. Pandas and PAN are not associated with the seizure, other atypical movement, decreased level of consciousness, and CSF abnormality. Pandas and PAN are inflammatory findings are usually absent, and the disease actually mechanism are unclear. So in case of pediatric Pediatric autoimmune neuropsychiatric manifestation associated with the streptococcal disease. PAN is the pediatric acute onset neuropsychiatric disease. Syndrome.
The statement's not correct, it's not associated with seizures. It sometimes manifests with seizures at the onset itself. So that statement is not correct.
Okay. Brain MRI and EEG are usually unremarkable in patients with the PANDAS and PAN, but are abnormal alone or combined in more than 90% of patients with autoimmune encephalitis. The criteria of the PANDAS and PAN, criteria of the PANDAS is all 5 diagnostic criteria must be met in presence of OCD or the tic disorder, and prepubertal symptom onset, age of onset and 3 to 12 years of age, acute symptom onset and episodic the relapsing remitting course, and temporal association between the group A streptococcal infection and associated with neurological abnormality, particularly hyperactivity and coriform movement disorder. And criteria for PAN is the abrupt dramatic onset OCD or severely restricted food intake, and 2 of the 7 should be matched. One is anxiety, emotional ability, or depression, irritability, aggression, or oppositional behavior, behavioral regression, deterioration in the school performance, sensory or motor abnormality, somatic sign and symptom including the sleep disturbance, enuresis or urinary infrequency, are not better explained by the known neurological or medical disorder such as Sheehan-Hans chorea, SLE, or Tourette syndrome. Now come to the new onset psychosis exclusion from the autoimmune encephalitis and seronegative autoimmune encephalitis. The new onset psychosis is misdiagnosed as autoimmune encephalitis. Patient, unless they have NMDR antibody in CSF or evidence of the paraclinical alteration like CSF or MRI inflammatory change, EEG abnormality, should receive conventional psychiatric treatment without immunotherapy. The new onset psychosis also the differential diagnosis no inflammatory change for CSF exclude seronegative autoimmune encephalitis. Actually, madam, new onset psychosis may present as a case of autoimmune encephalitis. Yes, ma'am. Yes.
During that aggressive immunotherapy may not be initiated in the absence of any physiological states of inflammation or more findings. That's what you mean.
Yes, sir.
And it follows my tell that it's going into more self-defense syndrome all the time.
How to increase the yield of autoantibody detection? The seronegative autoimmune encephalitis due to the secondary to novel autoantibody and mediated by as yet unrecognized neuronal surface antibody. So we should need the both CSF and syrup study, optimization of neuronal antibody testing and brain immunohistochemical assay. How to optimize the neuronal antibody testing? The diagnosis of autoimmune encephalitis could be improved by the comprehensive neuronal antibody testing, the brain immunohistochemical assay or cell-based assay. Many antibody to intracellular antigen can be assessed with a single assay, immunoblot strip containing multiple antigen, and require individual each antigen. So 16 different cell-based assay for each sample, serum and CSF. The rodent brain tissue immunohistochemical assay actually is the new diagnostic method that overcome many of the limitations of the current testing strategy. The methodology of the neuronal antibody detection in the cell-based assay actually targeted to the extracellular antigen antibody. So in that case, cell-based assay is required for that. For diagnosis for intracellular antibody, immunoblot is used. Radioimmun assay, anti-GAD65, anti-VGKC. ELISA test for the anti-GAD65 and tissue indirect immunofluorescence or immunohistochemistry require expertise in interpretation of the neuronal antibody tissue staining pattern, can be used to screen rare or novel neuronal antibody against the intracellular or extracellular antigen to maximize sensitivity, can be used to corroborate positive immunoblot or CBA result to maximum specificity.
It's a model. In cell-based assay, the Kiren Casper to another. Immunoblot again, anti-VDK radioimmun assay again.
Hello. Yeah, 65 is not meant for all of it. When we have discussed in the weakness, which is the most, reliable one, whether it's cell-based or anything, or just radioimmun assay or an ISO. It will have an option of doing that. Especially with a gas associated.
GAD65.
That was a question.
GAD65
GAD65 and all
Is-
that. Can be done with taking of this. And for that.
cell basis.
Yeah, cell-based is it. Cell-based is it.
More
It can be simplified that is the best one. We should convey that also. Should go for an ELISA. When you have an option of going for a cell-based assay. Yeah.
cell basis is more important investigation for diagnosis of the autoantibody panel.
Understanding about the methodology to detect specific antibodies required. Looking at research for more sensitive benefits. Here there is a model, LGA1 Casper 2 and then anti-VDKC. What is the
Brain tissue immunochemical assay able to detect most antibody against the neural surface antigen except for the antibody to the 2 receptor. And also it detect the antibody against the glial antigen aquaporin 4 and GFAP should be identified except the subset of the MOG antibody. So the patient with both CS on the brain immunohistochemistry and negative for glycine receptor cell surface antigen. Now come to the management part. In acute management, intensive care unit main indication from the ICU admission in autoimmune encephalitis include refractory status epilepticus, severe dysautonomia, and respiratory that is brainstem involvement, neuromuscular syndrome, or medicine-induced hypoventilation. If there is a massive inflammation or a brain edema, intracranial pressure monitoring and management may be indicated. Empirical antimicrobial treatment is not for the subacute case, it is for the acute case. It is the most common practice to start with CNS dose of the IV acyclovir and standard coverage of bacterial meningitis. Antibiotic and the acyclovir can later be discontinued with CSF bacterial and also viral maybe herpes virus or zoster virus study return negative. Several retrospective studies have shown that early and aggressive immunotherapy is associated with better outcome in autoimmune encephalitis patient. In 2016, autoimmune encephalitis clinical criteria emphasized the importance of the starting immunotherapy once autoimmune encephalitis is highly suspected and infectious etiology are excluded based on CSF result. It is impractical and potentially hazardous to delay immunotherapy until autoimmune encephalitis confirmed by the positive antibody test. There is no robust clinical trial comparing the different modality of acute immunotherapy. Therefore, the choice of initial therapy may be based on the anecdotal evidence. We first go for the high dose 7 days. Common reasonable approach to achieve initial immunosuppression and anti-inflammatory effect of autoimmune encephalitis. Autoimmune encephalitis associated with onconeural antibody that is primarily T cell mediated. So corticosteroid prefer option for immunosuppression over IVIG or plasma exchange. The use of the corticosteroid may also be difficult in patients with the common comorbidity like uncontrolled hypertension or diabetes. When primary CNS lymphoma is of differential diagnosis, corticosteroid should be delayed. Now come to the IVIG. The dose is 2 grams per kg over 2 to 5 days. When corticosteroid are contraindicated or when clinical picture is suggestive of antibody mediated, side effect is increased thromboembolic risk. Used with caution in patient with known or suspected paraneoplastic autoimmune encephalitis or other risk factor of thrombosis. Plasma.
Additional concern is the portion. With respect to paraneoplastic autoimmune encephalitis. What happened?
Thrombotic.
Why you need to be additionally cautious for 5 days? Here.
One is enough.
I was not sure I asked him.
That's the IVIG act on the FC receptor.
Is it a lack of efficacy or a compromise the lack of efficacy or is it a particular kind of side effect?
Statement why is it use of caution suspected parameter? The thrombosis of gates, cardiovascular power. What's the mechanism function by using? Second speed attaches to the FC, the filter of the antibody, the antibody that is responsible for the so what happens? Obviously, immunomodulation. And what is the rest of the benefit? What is the answer?
5 years and
All 5 minutes they are not there. So this immune complex is formed to activate the complex system. So when the strong set it's also working. Yes, both on the B-cell mediated immunity as well as the B-cell mediated. Earlier the thought it has only effect on the B-cell system. But then SSP and all use IgG because it's effect on the B-cell immunity also. So because all these risks sometimes they depending upon the nature of the paraneoplastic syndrome, can come up on flare up in a very different this one. I guess it's very complicated, but these people supposed to know this will be discussed. There's multiple reasons to match. So we get these things in the also the people in the regular also in the last 3 years it is done. But sometimes it can be plan about the paraneoplastic surgery. When you give IVIG, give that in the silver.
Now come to the plasma exchange. Plasma exchange actually 5 to 10 session every other day is effective option for the acute immunomodulation when corticosteroids are contraindicated or ineffective. Plex may be particularly effective in autoimmune encephalitis case that is associated with the central demyelination or coexisting NMOSD. Major limitation include increased bleeding risk, volume shift, which can be problematic in the dysautonomic patient, and another condition, the need for a central line for Plex therapy. Combined first-line therapy, if the initial clinical picture is severe, like NMDA antibody encephalitis, NORS, or severe dysautonomia, clinician may consider using combined first-line therapy despite the lack of high-quality evidence to support of this practice. More commonly, combined therapy is done sequentially if there is no meaningful response to the initial agent, adding IVIG or PLEX after completing corticosteroid. Second line therapy, if there is no meaningful clinical or radiological response to optimize first line therapy, after 2 to 4 weeks, the addition of second line agent with both rapid and sustained immunosuppression effect can improve the outcome. Both rituximab and cyclophosphamide has been used as a second line agent for rescue therapy in autoimmune encephalitis with good result. Common rituximab doses regimen include 375 3 milligram per meter square weekly for 4 weeks, or 2 dose 1000 milligram 2 week apart. Common dosing regimen cyclophosphamide includes 600 to 100 milligram per meter square once monthly and for 3 to 6 months. This is actually proposed treatment algorithm for the autoimmune encephalitis. That is actually Canadian consensus guideline. It is published in 2024. They actually suggest that initial treatment will be the definitely high dose steroid along with IVIG or PLEX. If treatment failure, so they lack of response or worsening 5 to 10 days after initiation of the first line, those who are admitted in hospital, and those who are outpatient, that response failure is 2 to 4 weeks after the treatment. After that, the confirmation of the extracellular, if the extracellular antibody is positive or antibody is negative, in that case they use rituximab. And those who are intracellular antibody positive, they use first the cyclophosphamide at the dose of 600 to 100 milligram per meter square and monthly 3 to 6 months. And they consider rituximab, especially the antibody with the neoplasm, in the lower level of the neoplasm association, like GFAP or GAD. All patients, actually, they consider co-administration of in that condition require the consultation with specialist in autoimmune neurologist. So in that case, they consider 2 drugs. The third line agent. Yes, ma'am. Sure. Actually, they didn't say anything about that. That needed actually the relapse is monthly IVMP is very user.
He does every time. I know RCPs, last one is not more. The each instance is so tiny. We are focusing today on seronegative. But this is the only thing that is having
Yes.
Canadian guidelines. Yeah, so the third one, antibody negative fans, the rituximab 1 gram for 2 weeks, 2 weeks. For how long should they give them?
They're not mentioning it.
And MRI, it goes to the base. I don't give basis on the very good. When we used to do MRI of it's nothing very specific. But all something it could be a little which is resembling and then we get steps. Or it could be some multifocal given their bands. Well, not specific. We have nothing to go by. We cannot with the patient then and then basically check that whether it turned out to be an MPN. So it's all a clinical follow-up that we have done. Including the seizures. Seizures were well controlled and that they come earlier seizures. So you should have a strong suspicion that it's some other syndrome. Admit and re-admit and that's what we do. Acute onset psychosis after a period of revision for an onset. Acute onset symptoms. Otherwise, the follow-up and all is going away. You're not supposed to, a very normal person is plateaued. You're not supposed to count in monthly, IVG, cyclophosphamide, or what's happen. Maybe for a period of 6 months. And we'll take all of the patients. So always better if one person follows the patient. If you have one patient. So we will still have presence. There are bigger administrators. There are also students that are about to do administration. Yes, but how we must see that. The reform select. All we consider cancelable. Other it is all clauses are there. You should read the article completely. Clauses are if there are features which are awful, we should give it a set of symptoms, whatever it is. But there are rules of persisting despite your acute treatment. Then this whole process should continue again and again. The next thing is after a period of going into remission or say they had a period of good amount of time where they not even symptoms again come back. And MRI is never proposed as a follow marker in autoimmune encephalitis, especially in Seronegative. Seronegative is the closest differential diagnosis is nerves. And now we all know about she is both seronegative and nerves also, start with dryness and crashing in super inflammatory states. This is important because it's this late in the last 1 year. Quoted that the UUs and the importance of tocilizumab in seronegative autoimmune encephalitis is what we did for that girl. After that, she improves for diabetes. Come to that.
Come to the third.
People are always landing on to rituximab. This has to be in the picture when it is seronegative autoimmune encephalitis.
The third line agent, the few case series have shown that who did not respond quickly to conventional second line therapy respond to tocilizumab and bortezomib. Tocilizumab is the interleukin-6 inhibitor, receptor and monoclonal antibody. Dose is IV 8 mg per kg every 4 weeks. Maximum dose is 800 mg per infusion and may be used in subcutaneous 162 mg weekly or bi-weekly. Duration of the therapy usually 3 to 6 months depend on response. And bortezomib actually proteasome inhibitor, that is block C cell plasma cell, that is plasma cell generation. Dose 1.3 milligram per meter square. Route actually subcutaneous preferable route more than IV. Schedule of dose of day 1, day 4, day 8 and day 11. 2-week cycle. Cycle actually they are recommended the 1 to 2 commonly used, but it may be used up to 4 to 6 in some refractory case. And for both tocilizumab and bortezomib actually often combined with the rituximab and or corticosteroid.
Tocilizumab came into the picture because that will prove that IL-6 inhibition is also a feature of seronegative autoimmune
Encephalitis.
Therefore, in cases when they are not responding to all the primary drugs, including whatever you said, plus rituximab, tocilizumab has to be administered in seronegative autoimmune.
Tocilizumab when used in seronegative autoimmune encephalitis because the mechanism is the interleukin-6, and when there is primary drugs like first generation and second line treatment is failure, in that case tocilizumab may be used. The seizure management in case of no, madam. Immunotherapy, they told that who becomes seizure-free, the gradual weaning of the ASM is required, can be considered after discussing that because the chance of later on the epilepsy. So recurrence, seizure may be recurrence and the chance of epilepsy later on may happen. And now come to the literature. What does literature say about the treatment of the seronegative autoimmune encephalitis? This is seronegative autoimmune encephalitis, clinical characteristics and factor associated with outcome. It is published in the Brain Journal. The method is a retrospective study. The total patient, they actually selected 54 patient, including 454 patient, that 119 patient is the antibody positive, 147 patient are seronegative autoimmune encephalitis. Other didn't meet the diagnostic criteria of the possible autoimmune encephalitis, and total duration of study is the 2 years. It's the retrospective study. They actually introduce one score, that is a rapid score, for the prognostic purpose. Rapid is the refractory status epilepticus, age more than 60 years of age, probable antibody negative autoimmune encephalitis, infratentorial involvement, delay in immunotherapy more than 1 month. Rapid score can be useful tool for predict 2-year clinical outcome. Actually, the cutoff point is 2. If there is more than 2 in rapid score, the significance, the criteria is significant for the study.
More than
More than 2.
more than
More than 2 for significant for the outcome. Outcome. In that study, they used for the treatment for first line therapy in corticosteroid IVIG. Second line therapy, they used rituximab, and third line, they used tocilizumab or cyclophosphamide, administered sequentially or in combination. The result of the study is the immunotherapy using immunotherapy like steroid, IVMP, IVIG, rituximab or tocilizumab was effective in this disease. Combined immunotherapy was feasible, especially then a high rapid score, high risk, that is score 2 to 5. They already show that MRI absence of diffuse cerebral atrophy or mesial temporal atrophy indicate that possibility of recovery. The comparison of the study, the good 2-year outcome, MRA score 0 to 2 for the seropositive case is 74.4%, and seronegative is seronegative is less, that is 56.5%. That is outcome of 2 years outcome in the MRS 0 to 2. The explanation of seronegative autoimmune encephalitis, why the drop down of this result, because of the seronegative autoimmune encephalitis may involve cytotoxic or irreversible mechanism compared to reversible antibody mediated process in seropositivity. And seronegative autoimmune encephalitis has more heterogeneous and mixed pathomechanism that are refractory to conventional immunotherapy. Patient exhibited the persistent disease at 6 months, that is MRS more than 3. Continuing immunotherapy was associated with more improvement, and who exhibit persistent disease at 12 months, that is MRS more than 3. Continuing immunotherapy beyond 12 months, not significant improvement. And duration of immunotherapy must be decided on the patient by patient basis by carefully considering the patient. So duration of immunotherapy in seronegative autoimmune encephalitis, there is no consensus protocol of immunotherapy in autoimmune encephalitis. It is a major issue to decide whether to continue immunotherapy in patient with a Another study is published in the Frontier Journal, Therapy Response in Seronegative versus Seropositive Autoimmune Encephalitis. The method is a retrospective study, 150 autoimmune encephalitis patients treated 2010 to 2020 years. Actually, 76 patients is seropositive, 74 patient is seronegative autoimmune encephalitis. Treatment response were treatment response were assessed using clinical impression and modified MRS scale. The comparison between the seropositive and seronegative autoimmune encephalitis, patient receiving immunotherapy 86.8%, and seronegative is 73%, but response is good. 92% seronegative patient had the good response, and favorable long-term outcome MRS is 60 less for the seronegative, and initial MRS score was 2.9 plus minus 1, and the more in case of the seronegative. And use of the rituximab in case of the seropositive, they use rituximab seropositive 26% of the case, and 9% of the case they seronegative. they actually use the glucocorticoid, that not the more aggressive treatment in the second study. It is the Barzer et al., that is the glucocorticoid used, or other first line therapy like IVIG, plasmapheresis being given to the most of the patient, regardless whether they are seropositive or seronegative. Two study, one is the Lee et al., that is study for prospective study, another is the Barzer study. Comparatively, we can see here, in case of the Lee et al. Study, they aggressively manage the patient, like they use rituximab, tocilizumab, or cyclophosphamide. But the later study that they goes less aggressive management. But in case of the less aggressive management, seronegative patient are response more. The 93% case are the more responsive, and here 57% case respond for treatment. Good outcome. So what is the explanation behind that? The seronegative patients are presumably heterogenic, so including patient with the low antibody against yet to be identified antigen with cell-mediated immunity, but sometimes that is non-immunologic etiology in some patients. So expected the therapy would be heterogenic. High efficacy indicate a significant role of the B cell seronegative case, and pathophysiologically antibody-dependent immunity play a role. Because of the heterogeneous mode of, because different mechanisms, so it is not a straightforward. Low. We detect the case also.
Now what we got is years later.
Maybe seropositive, because of the analytic procedure will be the improvement of the analytic procedure, and also. Now come to the important point of today's discussion. Heterogeneous group of disorder. Extensive diagnostic workup is required for diagnosis of the seronegative autoimmune encephalitis. Failure to detect antibody, it may be due to the novel antibody, non-antibody driven mechanism, technical limitation of the current assay. Treatment similar to that of used in seropositive autoimmune encephalitis. And most important, the thing is the start immunotherapy immediately. There is no consensus on protocol of immunotherapy in autoimmune encephalitis. Duration of the immunotherapy must be decided on the patient by patient basis. Refractory to conventional immunotherapy due to heterogeneous and mixed pathomechanism. More advanced antibody detection technique and immunotherapy regime or specially designed treatment strategy may increase outcome of seronegative autoimmune encephalitis and near future. Thank you.
At this point of time, if acid is a zero positive contaminants, because the reason
Isn't it?
said, and to that the quality add reasons, mechanism also has been detected to operate in this. The whole autoimmune is happening, but when you have a specific antibody to get from the whole giving process, so that it can be given in both. Because it is a major role to play that as well. And it's optimal recipe for us. It's not that we don't have any other theology to hang around that we are found in all these modifications, especially when the residents refractory status. The root cause has to be treated, not the super refractory status. Bone has to move very fast and have been handled. Thank you.
Any other questions to? Absence of any high whatever consensus guidelines are available. Because highly active immunotherapy is required, it is important to make maximum efforts to make a positive diagnosis of seronegative autoimmune encephalitis based on whatever consensus guidelines are available, and to rule out all mimics. And for duration of treatment, again, we can use our own clinical judgment, and we can also take into consideration whatever guidelines have been given of the duration of around 6 to 12 months for mild cases, 1 to 2 years for moderate to severe cases, and around 3 years for relapsing cases. So there are no other questions. We can end the session.
We can end the session today.